Dr. Prabhakar Koregol will address the issue of Finerenone, a new kid in the block of the group of drugs called mineralocorticoid receptor antagonists. We will have a discussion on the previous talk by Sunil, by Dr. Murthy. A comment from him is warranted after the next talk, sir. Yeah, go ahead.
Thank you, sir. As he's setting the laptop, let me say. This afternoon, I'll be talking on Finerenone, a relatively newer molecule for the most of the people, unlike lots of discussions we had since morning, where most of you have an experience, probably about this molecule. Very few of us have treated very few patients with. So, but again, as a was, this thing cannot be covered under the 10 minutes time that's been allotted. I'll just have a brief introduction and the answer another 4 questions, 2 minutes each. Finerenone, why another MRA? And we'll come to the questions as we go along. What is it? It's a newer version of mineralocorticoid antagonist, or the MRAs. The most commonly known ones are the aldactone and the eplerenone. It's a non-steroidal selective MR antagonist which is activated by aldosterone and cortisol and regulates the gene transcription. It blocks the MR-mediated sodium reabsorption and MR overactivation, and MR overactivation is thought to contribute to the fibrosis and inflammation. And it's a full antagonist. The other 2 molecules that we use commonly are partial antagonists. So the complete blockage is expected to happen, which makes it a highly potent and the selective drug for the MR antagonism. And there's no affinity for the androgen, progesterone, estrogen and glucocorticoid receptor, which produce lots of side effects with the previous MRAs. So the question is, why another MRA? Despite the current therapeutic options, patients with diabetes, most of them come back with a renal failure or the renal dysfunction, and majority of them develop cardiovascular events. This is despite of everything the diabetologists have done to improve the control. Beyond the metabolic and hemodynamic aspects, which are well controlled by currently available molecules, there still remains a chronic inflammatory patterns, which we are all aware. These little explored, but extremely important in determining the renal and cardiovascular outcomes. Chronic inflammatory patterns in patients can evolve into fibrosis, which affects most commonly the renal and the cardiac function. So that is where we needed a new MRA. The antiproteinuric and the antifibrotic effects of spironolactone, a steroid type mineralocorticoid receptor, has long been known. We have plenty of trials. However, such effectiveness has been burdened by a high incidence of side effects like gynecomastia, hyperkalemia, and worsening of the renal failure, which has not been mentioned here. So this calls for a new MRA, and which the position is being tried to be filled by Finerenone. Finerenone is a non-steroidal type of MRI. It exhibits the balanced tissue distribution, and most importantly, it is associated with a lower risk of hyperkalemia. So obviously everybody will ask, okay, we have so many trials with eplerenone, spironolactone, what about the Finerenone? Finerenone has plenty of trial evidence over last 2 decades, but what I have chosen is 1 trial for the cardiovascular outcome and 2 trials for the diabetic nephropathy, and later on the data from all 3 trials was combined to look at heart failure outcomes. So we had a very detailed talk on the cardiovascular kidney metabolic syndrome in the morning. Cardiovascular kidney metabolic syndrome is an emerging entity that connects the kidneys, chronic disease, and diabetes. strong epidemiological overlap and shared mechanisms. And looking at this combination, there's a potential for the individual therapies to simultaneously improve multiple adjacent disease states. So we need to try to find the common link between the diseases and the single therapeutic options. So I'll skip this. And question is this another diuretic? No. Most of the times, even when we use aldactone or the spironolactone, we don't use it much as a diuretic, more as an anti-proliferative, acting at the smooth muscle cell, cardiomyocyte cell, endothelial cells, osteoblast, and the myeloid cells and the T cells. There are multiple points where this molecule works. So the 3 trials all of us should know before we start using this molecule are the prospective randomized trials, that's Figaro-DKD, and fine arts heart failure, which all was come into the fine art heart meta-analysis. So what these people tried to look at, they saw you have a diabetes, you control the diabetes, but still lots of residual risk of kidney disease. Figaro-DKD and Figaro are similar this thing, except that the patients were stage 3 and 4 in the Fidelio, and in Figaro they were in stage 1 and 2 of a CKD. There was 18% decrease in the CKD progression, 14% decrease in the CV mortality and morbidity. Similar but small number because the overall incidence will be lower in the stage 1 and 2. So these 2 trials told this can be used in stage 1 to stage 4 CKD, moderate to severe albuminuria, good glycemic control and blood pressure control, on maximum tolerated ACE and ARB. Still the residual risk exists, and that can be treated with MRAs that are well tolerated. So this is again the same data. Then came those actually started as a molecule for renal protection, but when they saw the data, there was so much of cardiovascular benefit. The next trial was designed. That's a fine arts heart failure, which NEGM editorial says the latest masterpiece for the MRAs in the heart failure. Why so? Because we all know there's very robust data from rails and other things, but that was mainly for the heart failure with the reduced ejection fraction. But here, they looked at the evaluation. We did have a talk on the heart failure with preserved ejection fraction, and most of us do understand there are very limited therapies. But in fine arts, what they did, they took the patients with a symptomatic heart failure with preserved ejection fraction, mid-range ejection fraction, 40-year or old, class 2 to 4, LVEF more than 40%, NT-proBNP more than 300, and they're randomized to placebo versus the Finerenone. And there was a significant improvement in most of the primary endpoints that they looked. Mainly we look at the heart failure, hospitalization, cardiovascular mortality and morbidity, and CV death, pre-specified sensitivity, also in secondary endpoints like kidney composite endpoints, heart failure hospitalization, CV death, new onset atrial fibrillation, major adverse cardiovascular, all-cause death. For everything, the therapy was, therapy with Finerenone was more favorable than the placebo. And one more important outcome that came here was the graphs started diverging very soon. Many a times we get the benefits of therapy after 6 months, 1 year of starting the therapy. But here, within first few weeks, the heart failure hospitalization started decreasing, the mortality started decreasing. Of course, the composite kidney endpoints did take some time. And worsening heart failure in the placebo versus in Finerenone, and death from the cardiovascular disease. You can see the difference in the chart form here. Hyperkalemia did occur, but the only difference in this trial in comparison to the other molecules was There were no deaths related to hyperkalemia. There was no hospitalization requirement in most of the patients. So those are the 3 important trials, and later on about 18,000 of the patients who were enrolled in these trials were analyzed for the cardiovascular outcomes, which also came up with similar results. So just for the understanding, it comes in the tablet form, 10, 20, 40 milligrams. We have 2 indications from all the data that we had. One is in the patients with diabetes to prevent the progression of renal disease or the chronic kidney disease. These are the people whom we already have a CKD, are the people who have a reduced eGFR, are the people who have a proteinuria. Starting dose will be 20 milligram if the GFR is more than 60, 25 to 59 of eGFR 10. If eGFR is less than 25, currently it is not recommended. After 4 weeks, increase it. And in heart failure, it is indicated to reduce the cardiovascular death, hospitalization for heart failure, urgent heart failure visits in adults with heart failure with LVEF more than 40%. Most of the other molecules we use in the people with less than 40% are the reduced ejection fraction. Starting dose, again the similar, and then you keep increasing the dosage to a target dose of 40 milligram if eGFR is more than 60. If it's between 25 to 60, target dose is 20 milligram. I would skip this dosage modification and this one. So based on the GFR and when the DFR changes, there's a need. In the mild and moderate hepatic dysfunction, there's no need to change the dosage. But in severe, that's child who C, class C, we need to avoid these medicines. Monitoring, as with any MRA, we need to monitor the potassium levels. Do not initiate if serum potassium is more than 5. Initiate the therapy if it is between 4.8 and 5, but additional serum monitoring within first 4 weeks. And then measure serum potassium 4 weeks after initiating treatment, and dosage adjustment and periodically during the therapy if adjustment is needed. Major adverse effect is hyperkalemia, which occurs in 14% in patients with renal dysfunction. And the other problems are the renal impairment, reduced eGFR, and acute kidney injury. There is substantial drug interaction. You need to pull up your chart and see CYP to C18. So at the end of this thing, speaking as a cardiologist, we now have 2 sets of MRAs. One is steroidal MRAs, that is spironolactone and the eplerenone, which are the partial agonist. They are low potency, dose-related increase in the potassium, and less selectivity and more sexual side effects. Whereas Finerenone is more selective, higher potency, lower rates of the hyperkalemia, greater selectivity, and minimal or no side effect. It is still a molecule which is in progress. There are lots of studies that are looking at both in the people with reduced ejection fraction and the preserved ejection fraction. There are multiple ongoing trials. Of course, confidence is published, but I have not included as a part of it here because it was looking into the combinations. This is a kind of residual risk that will be left despite of the therapy with the regular diabetic medications. And obviously the people would ask, most of the things I spoke is done by the SGLT2s also. What's the role? Of course, it goes as a combination along with the SGLT2, and both of them act as a additive molecules, and there's no additional contraindications of the indications. This we have already spoken. So indication summary would be chronic kidney disease associated with type 2 diabetes and heart failure with preserved ejection fraction. Thank you.
Thank you, Dr. Prabhakar. These 2 presentations are open to question and comments, brief questions and a brief comment. First by Dr. Murthy, my good colleague. He will just take about 1 minute and I'll stop it at the end of 1 minute.
You don't want to say. Hello. See, blood pressure is actually, everybody thinks it is controlled. The main problem we are facing is patients discontinue because they record 2-3 times daily in their home. And once home BP monitor is normal, they will stop it. That is one big disadvantage we are seeing. A second one, what is the lowest? According to Dr. Goel in 80s, 100/70 is the normal blood pressure in Indians. And 110 should be treated. And it is again coming back with 120. 120/80 is taken as a standard. And everybody, so we have to treat whether we have to bring it down to that level. Or if somebody's blood pressure is at 25 years, is 80/60 or 90/60, these recordings we are getting it. These are my recordings. And if that is the case, whether we have to take it as a baseline, and if it increases, we have to put the patient on medicine. This people should answer.
Yes, she will answer.
Now, this is the important thing. If my BP is 80/60, at the age of 25, I am all right. I am doing very well. Do you see my BP, tomorrow my BP will become 100. Do you want me to treat or don't want to treat?
Okay.
This is the not numbers.
Okay. So that means you mean to say that systolic blood pressure is
Yes,
82, it becomes 100.
80/60, there are a lot of people are there.
Okay.
They are happy.
Okay. Sir, I'll just take you across through the journey of the blood pressure treatment so that how we understand. So if you're going to look at your blood pressure lowering treatment trial is collaboration. Any patient who has got a high blood pressure, you reduce the blood pressure even by 5 millimeters of mercury, you're going to get a significant cardiovascular benefits, including everything. So then what was happening here was actually, you reduce 5 millimeters, 10 millimeters. There's a concept called as the residual risk. So that means even if you're bringing down the absolute risk reduction by, I'll just tell you, sir, actually. So once you start bringing it down, so now the targets are moving lower and lower. The reason is only the residual risk. So that means you bring down the blood pressure to 140 and less. More and more events are happening in the blood pressure ranges between 130 to 140. So they are bringing it down to less than 130, 120. So that means this is an absolute number. But if you want to look at your concept, actually a patient who has a BP of 80, 90, and it moves to 100 or 110 subsequently, obviously we are not going to treat this patient actually.
No, that's what this thing.
So,
Dr. Goel, when he brought out his work in 1980s, all of us laughed when he said that normal BP for Indians is 100/80.
Sure.
He said, I think you remember that.
Sure.
Everybody laughed at it. Now, when we went from 140/90 or 190/100 plus age, we are again coming down by 139, 120. We are coming down like that.
Yeah,
So,
I'll tell you.
now I am telling a situation. I am seeing my patients, their children now.
Yes,
They are weaned off from their pediatricians.
sure.
So now we are recording these children's blood pressure. To my surprise, I am finding out what Dr. Goel has said right. So whether we have to start treating at Dr. Goel's point, that is 110.
I'll tell you, sir. It is actually seeing through a retrospectoscope that the blood pressure which is higher when it is treated with some intervention, the life becomes better, the interventions affect the target organ dysfunction. What we don't know is if a 80/60 blood pressure becomes over 10 years time, 100/85, should we be treating this and bring it down to 80/60?
Yeah,
It is not known.
it is not
It is not known.
not known.
Not known.
That's right.
It is not known.
That is
And such a data will be available eventually when you collect about 100 or 1,000 people.
like one more.
No, let me finish this, sir. You should be convinced. If you collect such people in hundreds and thousands and expose them to the correction with medicines or without any medicines and follow them up for 5 years and 10 years, and what kind of events you are likely to see in a person who is about 25 to 30 years old, I am not very, very sure. And nobody will support your research.
I think you should treat that.
No, nobody will support your research, not treat. Don't treat. Sir, don't treat. support your research because there is no money there. Hence, such an answer you will not be able to find in clinical medicine, sir. So you should be clear that incremental in the blood pressure does not give you the dictate nor the power to reduce the blood pressure, especially with medication. If the person has picked up a blood pressure of 20/10 over 3 months' time, you should evaluate why has he picked up any alcohol, does he pick up any weight. Such of these things can be very, very useful. And I will stop here this discussion. One more thing he had.
See, whether there is any cutoff, this 80/60 or 90/100, this 70 we are seeing in children. How much it will increase over a decade? Anybody has done decadal increase in blood pressure?
There is. See, when the men and women are followed up in the first decade and second decade and third decade, there's a gradual increase in the blood pressure in the modern times. The systolic tends to go up rather than the diastolic. In boys, it becomes a little higher when compared to the girls, and it seems to be related to the body mass index. We did this study in Sringeri of a long time, nearly 20 years ago, along with my friend Dr. Prasanna Kumar. We demonstrated that in the pediatric age group, the blood pressure tends to go up, and it is well known across the world. Thank you, sir. We will request Dr. Rao to be brief.
Sir, yes, sir, I am very brief only, sir. This is, in contrast to what we are discussing now, there are situations like elderly male who is about 70 years. His blood pressure is 180 systolic, 180, diastolic is only 80. My point is that you call it systolic hypertension. In such a situation, what is the medicine of your choice? And when you hammer the systolic, what will happen to diastolic? Because I don't want the diastolic to fall further. Yeah. How do you manage and what is your choice of medicine?
Sir, actually, when you're going to consider, this fits into an isolated systolic hypertension. If you're going to look at across the definition, either the systolic is above 130, diastolic above 80, either of the one, the patient is hypertensive. Obviously, you need to bring down the pressure head. Obviously, you need to treat. And you need to treat to bring down the blood pressure to the goal. Either you are going to put up a target of 140 or 130. Please bring it down actually. And what is very, very important is, because you know that proportionately the diastolic blood pressure starts falling, and that is where you have to be a bit careful about the tolerability of the antihypertensive medication to the patient because of the J-curve phenomena. In case if the patient has got an associated coronary artery disease, especially an obstructive coronary artery disease, these are the patients more likely to have an cardiac events actually. So what is very, very important is you need to bring down the blood pressure to the goal as long as he is tolerating your target drug, whatever you're going to choose. So provided this particular patient doesn't have any symptoms related to hypertension, doesn't have any orthostatic hypertension, and he's tolerating your medication, please chase the target to less than 140 if the patient is... Absolutely, sir. So usually, sir, elderly individuals are known to have low renin states. The best drugs will be either a calcium channel blocker, long-acting calcium channel blocker, or a diuretic. Then you can consider to add the RAS inhibitors. Very elderly individual, the first drug of choice will be still RAS plus or minus a combination of a calcium channel blocker because of the inherent side effects of your diuretics.
One important thing is if the blood pressures are higher in the lying down posture, check the standing blood pressure and use that as a target for your blood pressure management. That can be very helpful. With standing up, this diastolic tends to fall, and diastolic tends to go up, systolic tends to fall. So hence, there is quite possible that when the patient stands up, the systolic could be his normal blood pressure when he goes around and remains active. So that could be one of the targets that has been described by the experts. I cannot say that, that is the best way to treat it. At the moment, at least, it is better to control the isolated systolic hypertension. As you rightly said, it is a difficult subset of patients to treat. Diastolic will worry us, and things have been discussed already. So with this, we'll come to this section's, rather symposium. And can we go on to the next one? In fact, we have a very interesting topics, not often discussed. Thank you, Dr. Sunil Kumar. And before you go, we have to present a memento to you.